already gave all the symptoms and I recognize its toxicity, the highest priority is to basically discontinue and draw a labs.
Okay. Now, you are right. Anytime it says, excellent question, by the way, anytime it says priority, you got to think three things first. Maslow hierarchy of needs. Then you think, I'm sorry, ABC, airway, breathing, circulation, Maslow hierarchy of needs, and the nursing process. So nursing process here. So is it about Maslow? Well, it's about A, B, C, and D. A, B, and C. Well, if someone is talking, and if someone is already, if someone is talking to you and you're breathing, so that pretty much takes care of your airway, breathing, circulation. So next, it will be Maslow hierarchy of need. It's about safety, right? Do you have a safety place to go to? So it's not applicable to this question. Now it comes to nursing process. Your priority is to collect data, and your data would be collecting labs, would be to collect EKG. Specifically for this question, you want the EKG just because it's how it's related to the T inversion concept that we covered early. Okay, but generally you are thinking in the right track. But he is trying to say, hey, what do you know about lithium and how is it, remember the labs that we collect earlier? We said get an EKG, and how is lithium could cause arrhythmias and could cause a T inversion. So in this case, more specifically, lithium collecting EKG would be the best choice. Because if you are able to talk to someone and you are able to airway, breathing, circulation in 5 seconds, you already collected the information. So what would be the next choice, right? Would be to get an EKG. Okay, very similar, but you are right thinking that way. It's just a little nuance for this specific question.
Okay,
does it help?
Yes, it did. And I had another question. You think they'll basically be tricky with us to use that, with akathisia, the first drug would be that use that beta blocker. You think they'll give us like a patient with bronchospasm and would like us to see our critical thinking skills and say, okay, instead of using a propranolol, a beta blocker, we could use like anticholinergic like the Cogentin. You think they'll trick us like that?
For akathisia specifically, pick beta blocker. If the answer choice is between Cogentin or beta blocker, pick a beta blocker. But for anything else, Cogentin would be the answer choice. Secondary to no for TD, right? We don't do that for TD, tardive dyskinesia. But if it's akathisia, if there are two answers there, and there's one's Cogentin and one's propranolol, then propranolol would be the best option, followed by Cogentin. I don't think they would do that, but if they do, pick propranolol for the specific example of akathisia. Great question.
Okay, thank you.
A miracle.
Hello?
Hi there.
I have a question. Yes,
okay, go ahead,
I have
please.
a question regarding accessing the question bank.
Okay, so if you don't mind, we'll go over the question bank and how to access it at the end of the course, and I'll show you step by step.
Okay.
Because that way you can follow along with your account and you can access it with me. Okay.
Sure.
All right. My pleasure. Miracle de Dios, I think she have a question. If you can unmute yourself.
Hi, Dr. Lopez.
Hello there.
This is Tina.
Hey, Tina.
Yeah, hey, I don't have a question. I just wanted to encourage everybody. I passed my my exam on Tuesday.
Awesome.
Yeah.
Well done.
Yeah, I wanted to be kind of like, I sent you an email, but I wanted to like encourage everybody and kind of like give them a little bit of tips. Thank you guys. Thanks everybody.
Great.
I'm sorry. What I wanted to say was, I'm sorry, my kids are here. I'm
Okay.
sorry, guys. The kids are like following me
I
everywhere.
know.
But what I wanted to say is that everybody, please, please listen to Dr. Lopez, please, and go through the content, because I mean, the question is, the question in the whatever in what is it, the diagnostic test and the question bank, are they the same? Yes, they are similar. They are similar, especially for the diagnostic test. Two, one is mostly content based. It's based on content. You have to know your content to do one. But the second one is critical thinking, which was very, very good. And I can assure you, I saw some questions were exactly the same questions. Um, Maybe about 10 questions, but the rest was mostly content. You have to know your content. Otherwise, you're not gonna do anything. You have to learn, read, and read. Um, I did everything. I read the whole book. I watched all the videos, Dr. Lopez videos, all of them. And I did the sticky note. What I
Okay.
did was that I was writing on my sticky note everything he's saying about whatever lithium, about any medication, and I did all the question, even on the how to use the Kahoot questions. Every time there was a question, and then he would explain, I would write everything that I didn't know. If he says something new, I would write it down, and I put the sticky note in my bathroom because I use my mirror all the time, like maybe 50 times a day. So I put somewhere I could see every single time I walk somewhere in my bathroom. So that's how I was studying. I knew every time I'm in front of my mirror, I would see whatever it's about, lithium, about whatever. So that's how I had everything in my head. So every single day, I put all the sticky note everywhere. So I know I'm gonna go there maybe 3, 4, 5, 10 times a day, and that's every time I would go there, I read one sticker note, and that was really helpful to me. So I don't know if anybody can do that. If you want to do that, that's fine, but it's really helpful because you have the information at all time, and you
That's a
read
Okay.
it at all
yeah,
time.
that's a really good idea.
Yeah,
Yeah.
that's what
I-
I did. So they're still there because I'm still like, I still have to know when I start practicing. So my sticky note are still on my mirror because I have a bigger mirror. So I still have sticky note on, like, but I would say most of the medications, most of the all the numbers and everything. But what I would say is that on the test, I can assure you it's mostly critical thinking. They're gonna give you a scenario, not a scenario with a patient. It's like real scenario. One, a patient who comes not just with depression, but the patient will come with diabetes, hypertension, arthritis, infection. So how do you know if the patient is on lithium or Depakote? You have to know what kind of medication is, has interaction with lithium or whatever. You have to know all that, and for you to know, you have to go through the module. You have to go through the question, and also the Kahoot that he does. It's really helpful because he discussed how to respond to questions. And yeah, it's really important. And if it wasn't, I didn't use any other resource other than the book, at the ANCC, the review book, and his videos. That's just, I'm being honest. And if it wasn't for his
Thank you.
videos, I don't know, I wouldn't have done it. But also the review, I think he sent me the PDF. So I went through the whole PDF. I think it's 71 pages. I went through, but that's like a day before. That means like I was already ready. I knew most of the thing. I was just verifying myself.
Okay.
Okay, what is that? I just went through to say, to like make sure that I'm not missing anything. And I went through the whole thing. So please take your time. Don't rush into it, because it is, you have 3 hours and a half, but it feels like you have only 2 hours because you don't have time to think like through the questions. They are like really critical thinking, but you have to have a base where you know, like, okay, if I have this question, this is how I'm going to respond. And one thing that the cage, I don't know, they gave a scenario of a girl an adolescent who came in with who was using drugs, but also, so they gave, like Dr. Lopez, there was a question like that. He always bring up that question where you have to choose what kind of tool you're gonna choose.
Mhm.
So they gave cage, but cage with the drug,
Always.
yes, and then cage by itself, and then dash. So you have to know which one. I don't know if I chose the right answer, but I didn't. I spent like a 2-3 minutes on that because I was like, okay, I know you have to choose. What do you say? What is the other one? That's over cage. But then the little girl was using drugs too, so you
Mm.
have to know exactly which one you have to use. It's
Mhm.
really like the questions are really confusing because you would have 3 answers that are the same, and you have to know the exact answer, and that is
Yeah.
really important. But also there was one question about the anemia, macro
Mm.
macro what again, the word is
Micro and micro
yeah,
and
macro what
System.
anemia, whatever you guys say, it. But right now I'm just like kind of excited. I'm still thinking, I'm dreaming that I passed this test. But yeah, but that question, I know the answer is either uh uh either a vitamin B12 or folate. So
yeah,
you have to
9.
know in that question they give you the right answer. There are only 4 answers, and then they give one is the vitamin B12 and the other one is folate. So what are you going to choose between the two? So that's how they really give the question.
Okay.
That are the answers. So you have to know exactly which the right thing, the right answer. So for you to know that, then you have to go through the questions, you have to go through the content, and you have to take your time to go through everything.
Okay.
So
So thank
don't.
you very much. Yeah, it's very
Yeah,
important that people come back with their feedback. I get those
yes,
feedbacks and I answer that. So now
yeah,
let's go back to the question that you just mentioned about
yeah,
mm, microanemia.
yeah.
So is your B12 and B9. Now, if the question give you B12 and B9 both, it should be I think what you're referring to, it should have B6, B12.
Mm-hmm.
It should have
Yeah,
because of,
yes, but there's no
yes,
end. Like all the question, there was no end. It's either. So you have to know which one is more important than the other.
yeah. So that one would be super tough because what you need to do is you get your B12 and B9
Yeah.
and iron.
Yes.
Iron is not part of it, but because you wanted to rule out other things, iron, that's what iron comes in. But
Mm-hmm.
the answer is B9 and B12. And it should give you, ideally, it should give you what labs to collect.
Yeah, but unfortunately, that's not, because they are tricky.
Oh,
That's where the questions are tricky. That's what I say. You have to know,
yeah.
you have the content. Otherwise, you're not going to be able to, like, with the time. And you also, like, you're stressed out. You're looking at the time when you're doing your questions. You have to know the right answer. There's no or and end. There's no that. There's
Mm.
all the questions. They give you the right answers, but you have to know the most important answer. You know?
Can I ask you a
Okay.
question about it? Is it
Yes.
is it like the NCLEX where it's completely open and it's a bunch of people sitting at their own desk, or are you like
Yes.
in your own
Yeah.
cubicle?
Yes. It's exactly the same way, but there's cameras. There's like basically you can't even look because you are in your own space. But yeah, remember, everybody is there is not taking the same exam, and everybody doesn't have the same time.
Mhm.
So like
Do you
there are people who are there at 10 o'clock. Their appointment is at 10. The other 8. The other
right?
7. You don't know who's taking what. You don't
Do you
know that.
Okay.
do you at least have like walls up on the side of you, like a cubicle?
Yeah.
Yeah, it's just a
Okay.
So
cubicle, like where
Okay.
it's open, but just the computer is closed.
Got
okay.
it.
Yeah.
All right. So we'll go over a little bit more of the testing and the environment and things like that. But Tina, thank you so much for stopping in and then motivating everyone and then giving your feedback. I'm sure lots of people can reach out to her via the WhatsApp or WhatsApp community and ask any question. Like, guys, the question that we don't want to go over now because this is your study time, but ask. There's over 300 people in our group there, a lot more, and some of those people that have taken the test 2 years ago, right? So, and why they didn't leave? Because they're still there to support you and ask you questions. Like we have people that have been there for 3 years in our group, right? And they still there and they're still answering questions. So use those folks that have had similar experiences of the test taking, you know, taking my test a long time ago, and they can give you pretty much any answer, you know, from their own perspective. Yeah, for sure. But thank you, Tina. I really appreciate you coming in and giving us some insights. And I'm sure some people can reach out to you via the WhatsApp and kind of follow up with you. Thank you again for trusting the
Yes, I did take the for someone asked if he was ANCC. Yes, he was ANCC.
Okay, great. Thanks. Appreciate it. All right. Tope, we'll go back to you so the way we kind of proceed on the learning here. But please save your questions important, and then we'll go ahead and answer that during the next break, okay? All right, so hopefully you guys see it. So my screen, later, I want to share with you a few other tips for the test at the end, okay? So today we talked about a lot of things, and one of the things was lithium, and there's super high yield for bipolar disorder. Well, another super high yield topic is valproic acid, okay? So before we go to valproic, what Tina mentioned today, you got to know everything. And that's why the crash course review is super important. She said she looked at that a day before the PDF, right? So the PDF is located under the first video of each module. Now, this is the most important test of your life, right? So knowing everything is much better than just going for the crash course review, okay? So first thing you need to know about valproic acid. FDA warnings, 2 of them. What are they? Hypertoxicity and pancreatitis. Second thing you need to know about valproic acid is that what is pancreatitis and what is hypotoxicity or liver condition, right? So you got to know that. Now, again, second thing you need to know is that medication that could cause birth defects. And when we say valproic acid, first thing that comes to mind is spina bifida. Okay? So because there is a black box warning, for all medications, you do not need to know all medications, all the symptoms, all the crazy things. What you need to know is what they're used for, what's the regular dose, and what are the FDA warnings. Because pancreatitis, FDA warnings for hypotoxicity and, valproic acid, FDA warning, hypotoxicity and pancreatitis, what tests you need to collect when prescribing valproic acid? LFTs, right? Because it's the effect on hypotoxicities, right? Remember, value your liver for valproic acid, right? It's more effective than lithium for rapid cyclic. Remember, in the previous slide, we said do not give lithium. So what do? Valproic acid, right? And you need to know that the normal levels where you want to live is 50 to 125. Right? So if the level is way above that, then your action is to stop the medication, then collect labs. Okay? So again, valproic acid, spina bifida, 2 FDA warnings, hypotoxicity and pancreatitis, normal values 50 to 125, and stop the medication before collecting labs when you suspect hypertoxicity. During a pregnancy, if a patient takes valproic acid, the following condition would be most concerning regarding the baby. So, C, right? Steven Johnson syndrome. Which medication would be the high yield for Steven Johnson syndrome?
Lamictal.
Lamictal or carbamazepine, right?
Yes.
If the question is about Asian, then the answer is carbamazepine. Remember, you're likely to get Lamictal and carbamazepine related to Steven Johnson syndrome. How do you choose your answer? The race. Asian, carbamazepine, not non-Asian, Lamictal. Abstain anomaly. Which medication is high yield for abstain anomaly? Lithium, right? So because we know that, you think the question would be just simple as which of the following medication could cause abstain anomaly? No, it would not. Very, very rarely, because that would be too simple. What the question would be like: your patient that you've been treating for, you've been, let's say you've been assigned a new patient for bipolar condition. While doing your assessment, you heard a murmur, a retrograde murmur 5/2 of some kind. Which of the following questions would you most likely ask this patient? You know, and it may give you different scenarios. For a question to ask would be, has your mother taken lithium when she was pregnant with you? Right? So now you connect the symptoms of retrograde systolic murmur as loud as 5.2/5. Let's say that's the number that they gave you. With your knowledge of abstain abnormally, with the question, has your mother taken lithium while pregnant with you? Right? So it obviously would give you say the mother also has a family history, so forth. But now it connects what you know to the symptoms or questions to ask. Okay? Very high yield, what I just said about abstain anomaly, which is a heart condition. And Depakote obviously is spina bifida, and Down syndrome has nothing to do with none of the medications. When do you obtain a lighter job? Okay, so there you go. So there you have it. Okay, so please know the things that we mentioned now. Hypotoxicity, 50 to 125 is the levels that you want to do. Spina bifida, and we just cover a few other things about Depakote. So again, we are covering things that are high yield, right? So if we're covering in any of our modules, you are likely to see it on your test date. Then we do the crash course review, which is more of the same thing, but maybe adding few extra things and just giving a different perspective. So download your PDF, take it to the bathroom, take it everywhere with you. Okay? So we talked about lithium, we talked about Depakote. Next mood stabilizer is carbamazepine. So hopefully you guys can see my screen. I'm sharing. Okay, I'm sharing. All right. So when it comes to carbamazepine, what is important? Well, three things right away. FDA warnings: agranulocytosis, aplastic anemia. Well, what is agranulocytosis? Is a decrease in white blood cells, right? Now, aplastic anemia, think of bleeding gums, right? Your nose is bleeding, your gums is bleeding, fever, skin rash, and shortness of breath. Okay, you need to know those symptoms. Now, when choosing between Steven Johnson syndrome carbamazepine versus Lamictal. If the question has Asian in it, carbamazepine is the answer. If it doesn't, Lamictal is the answer. Before you prescribe carbamazepine specifically for the Asian population, which tests you need to do? HLA, or I call HLab 1502, because it helps me remember lab number 1502, HLab 1502. It's high yield associated with carbamazepine induced Stevens-Johnson syndrome. So you kind of get the test first, and then you see if you could prescribe that medication. Always ask, if you see a question that has HCG, you should be really looking to see if those medications could cause fetal defect. And for the test, primarily for the test, 12 to 50 years old is the age you want to screen for. Now, folic acid, it supports neurotube development, right, during the first few months. So dose is not important, but I want you to know 0.4 to 0.8, not really important, but folic acid is important to know. 3 rules for carbamazepine, or 3 A's that is stated in carbamazepine, which is first A for aplastic anemia, second A for Asian population, third A for agranulocytosis. All right, we covered a lot in a few minutes. Now, if you really care for mnemonic here, I use carbamazepines. C for color, A for agranulocytosis, A for rashes, B for bleeding gums, A for aplastic anemia, M for the MADs, stop the MADs, A for Asian. The HLab 1502, right? Then you got the carbamazepines with the Z added into it for sleepiness, it causes. P for pregnancy, neurotube defect. I for increased shortness of breath, remember, part of your agranulocytosis, aplastic anemia. And for nosebleed, elevated temperature for E. I mean, it's a one way to kind of just run down all the things that you need to remember. But as long as you know agranulocytosis, and as long as you know aplastic anemia, you should be good to go in that regards that we just mentioned now. Okay, so therapeutic range, right? You want to monitor between 4 and 12, not high yield. Okay, for seizure controls, because it's a medication that that could help with seizures, the mood stabilizer, and because it is metabolized by the liver, right? It may decrease the efficiency of other drugs, i.e. oral contraceptive. So in questions like that, it most likely would be something like, what advice would you provide to this patient that's taking oral contraceptive and carbamazepine? So using 2 modes of prevention, pregnancy prevention, right? So it's connecting what we know to what information you would provide. These are the type of questions that you have to think critically, right? CNS side effects, dizziness, drowsiness, ataxia are common, right? And it could cause hyponatremia. Oftentimes, hyponatremia is something that shows up with carbamazepine, also with lithium, but more high yield for carbamazepine, right? It decreased the serum sodium level, so you want to monitor electrolyte periodically during the treatment. Okay, just additional information to know. In Asian population, which medication among these options would raise the most concern? So we know, put all the mood stabilizers together, so we know carbamazepine. All right. So there you have it. We cover lithium. Now we'll cover the Depakote, to cover carbamazepine. And now it is the next module, which is, let me pull it up here. All right, Lamictal. So in this series, we are finishing our mood stabilizer that are most high yield. So you guys can see my screen, correct? Yes. Okay. So now Lamictal, right? What we need to know for the test for Lamictal. One, black box warning, Stevens-Jones syndrome. Two, discontinue the medication anytime you have rashes that is continuous. Right, pay attention now. If your patient is taking carbamazepine and develops a rash, the rash subsides or decrease. Your person is here today to discuss this concern. Option A, what would be your next action? Option A, discontinue Lamictal due to Stevens-Jones syndrome, continue the medication, prescribe a different medication, or reduce the dose of the medication. Guys, let me tell you, if
Continue.
it is continue, if it is Stevens-Jones syndrome, the rash will not go away. It is concerning, you should assess, yes, but it's not Stevens-Jones syndrome. So you continue the medication as prescribed. Okay? I know it can be tricky, right? Because Stevens-Jones syndrome is rash, but if it's severe rash, it's Stevens-Jones syndrome. Those with Stevens-Jones syndrome, they'll have fever, facial swelling, tongue is rash. If you open their mouth, they'll have rash everywhere. The skin is slaughtering skin, right? So joint stiffness, painful mucous membrane, right? So, but understand that Stevens-Jones syndrome, this is not going away. But rash is important, it's just not Stevens-Jones syndrome. So you continue the medication. When you so how do you decrease the risk for Stevens-Jones syndrome? Go low and slow, meaning if you care in clinical practice, 25 for 2 weeks. Come back, patient. I'll add 50 milligrams for 2 weeks. Now I'll tell the patient to come back. Now I will increase, double it again to 100 milligrams for 2 weeks, and I'll ask the patient to come back in 2 weeks. And finally, I arrive to my ideal number, which is 200 continuously. Now, don't have to use 200, but what I'm trying to say is you double up every 2 weeks. Not super high yield for the test, but for clinical, it's super high yield. Okay, so basically you go 25 and double 25 milligrams, and you double that every 2 weeks to prevent, because if you do get Stevens-Jones syndrome, then it is at a lower dose. Okay, you shouldn't. You should be able to really stop the medication immediately before you get there, or as soon as you get there. So effective manage for acute and preventing bipolar mood disorder, specifically the lows of bipolar, not as effective for acute. Okay, dose starting 25 milligrams a day, increase gradually to avoid severe rashes. Interactions may be reduced when you use with inducers, i.e. carbamazepine, right? Or enhanced with inhibitor valproic acid. Let's stop here. high yield. Your patient's taking lamictal and valproic acid. What will happen to the lamictal levels? Anyone?
Increase.
Increase. Almost as double. So super high yield. When you're prescribing valproic acid and lamictal together, your lamictal level will increase. So your action is to decrease with the valproic acid or decrease lamictal. More specifically, lamictal, says the question is about lamictal. Note that valproic acid and lamictal will double the value of lamictal. Not really double, but it will make it super high. But for test purpose, understand that you should not prescribe those together. If they are, you decrease your lamictal level. High yield, guys, okay? And it's easy to forget later on, next week, 2 weeks, 4 weeks later. That's why you write it down today. Lamictal and valproic acid together. Decrease your lamictal level because it will increase double of the volume. So mnemonic, M-lags for lamictal, recall the association for each letter. The M, the L, I'm sorry, the lamictal. The A is for acute management and prevention of bipolar and mood episodes. The M for mucous membranes for rash. I for interactions with the 450 inducers and inhibitors specifically lamictal, specific valproic acid, and inducer carbamazepine. C for close observation during the initial assessment. You want a T for titrate, slow and low. It could cause muscle pain or arthralgia, and look out for the life-threatening symptoms of Stevens-Johnson syndrome. Okay, so that is it for our mood stabilizers that we covered today. Remember, we are not covering everything. We are covering what you need to know for the board specifically, right? And putting a little clinical pearls to connect the dots along the way. Now, the next one is mania. Since we cover lithium, carbamazepine, Depakote, and lamictal, now we're covering the disease process, which is the mania, right? Or bipolar. Do not confuse bipolar with borderline personality disorder. So remember back in today's event when I said people will automatically assume that the medication added was inducers or inhibitors, when in fact it was nothing to do with the inducer inhibitors. So what does it have to do with? Forcelled. Okay? Forcelled. When this finished, I probably in the next an hour and a half. So this one's super important. I would put this on your dumping sheet. Forcelled. So if the medication is syphilis, SAM-E, steroids, and St. John Wort, right? So this medication could cause mania. So how the question comes? Your patient is stable on lithium. Later, he went to his primary care provider who prescribed a steroid of some kind, prednisone. It will never say steroid, it will say prednisone. It's your job to know the prednisone is a type of steroid. So now the patient is manic. Which of the following actions should you do first? So your action here is knowing that the patient was stable, something else was added. And that something else fall under the terminology here that we use for access, for sound, right? Which is medication that could cause mania. In this case, was the prednisone under steroids. So your action is to increase your mood stabilizer. It has nothing to do with inhibitors or inducers. Okay? The rest of the acronym, we cover the 4 S's, which is syphilis, SAMe, steroids, St. John wort / ginseng, right? All these medication could potentially cause mania for patients that have manias underlying. Yes, SSRIs, right? Antidepressants. So the A is for antidepressants. The I for isoniazid. The LE is for levothyroxine, levothyroxine, and D for anti-abuse. So when you have any of those medications in a question, the question is not about inducers or inhibitors. The question is about the medication that was added that could cause mania, and now it destabilizes your medication. So what we care, what you are going to do in that case is increase your medication. Or, second option, collaborate with the person that prescribed the added on medication. Okay, please go ahead, ask your question. This is a very important topic, okay? Whoever had the question, please ask. Unmute yourself.
It
Go ahead.
was an accident, but
Okay.
stimulants too can cause mania,
Mania.
right?
Yeah. Stimulants too can cause mania for sure. Absolutely. Because it increases the dopamine, and it could cause mania as well. So other things to remember is, thank you for the question there, anti-abuse or disulfiram could also cause birth defect, okay, neurotube defect. So add that to your disulfiram anti-abuse could cause birth defect as well, okay? So now, always consider the possibility of other drugs inducing mania in patients presenting with new onset symptoms, right? Shouldn't use the induced so it doesn't relate to inducers or inhibitors. I should say other possibility that could cause mania as the new onset. Specifically when the test says the patient was stable on X, Y, and Z, something else was added. Watch for the something else. Does it fall under this acronym here for SELD? If it does, your action is to increase your medication or collaborate with the other provider. Okay, so treat drug-induced mania by discontinuing or adjusting the causative mania and consider pharmacological interventions such as mood stabilizer or antipsychotics if necessary. Basically, you want to discontinue that medication, or more likely is to increase the dose of your medication. Okay? So there you have it. Can someone please read this question? Anyone?
A patient diagnosed with bipolar disorder is experiencing mania and insomnia despite being stable on lithium for the past 6 months. To assess if medication adjustments are needed, identify the medication known to cause symptoms similar to mania from the options below. A beta blocker recently prescribed for anxiety. B, benzodiazepine newly prescribed for panic attacks. C, treatments for a sudden flare-up of rheumatic arthritis. D, a recently initiated antiretroviral regimen for hepatitis. So
So the core of your question is which medication caused mania for a patient that was stabilized? Then you go back to your 4 celled acronyms to remember that one.
yeah, so sudden flare-up. Is it C?
Yeah. So here, remember that it will not say steroids, your test. I guarantee you that. It's your job to know that steroids is rheumatoid arthritis, is a medications that are giving for those or arthritis crisis here in this specific case. So it could say Flonase, it could say prednisone, or it could say a flare-up of automatic arthritis. Oh my God. Okay, so do you understand that they'll never say steroids? Possibly. I mean, they could be super nice and say that, but it's your job to kind of like, okay, this is a steroids. This is part of the four-celled acronym, and that is the reason why the patient became unstable. Now the test-taking strategies. Beta blockers could cause depression, not mania. Benzodiazepine could cause depression, not mania. And then these guys here, antiviral regimen for hepatitis. So that is part of your inducers and inhibitors, right? But then this is not about inducers and inhibitors. This is about steroid adding to the treatment that cause mania. Okay? Please memorize this acronym. It's going to come super useful to you. Okay? Because you need to know those medications that cause mania and the medication that cause depression, which will be next, and one of your inducers and inhibitors to get this question right. Okay? So is everybody clear on how we pick these answers, or anybody has a question here?
Could you please replay the slide that you have with the sale so I could just at least take a picture, please?
Yeah, so the previous slide, is that what you were referring to? The acronyms, let me start from the beginning. The four S's. First S is syphilis, second SAM-ES, S is for steroid, and S for Centron Worth. And the AILED, A is for antidepressant, I for isoniazid, LE. I've seen questions with LE, levothyroxine, before, was added, and now the patient became manic. What was the reason? LE, levothyroxine, was the reason. So what is your action? Increase your mood stabilizer. And D for disulfiram, which is anti-abuse. Okay, so very, very clear. I cannot tell you how many times I make this question on our diagnostic test, and we still have tons of people that get it wrong.
I have a question.
Go ahead, please.
Okay, how will I know whether I should, when will I know whether to discontinue or increase the mood stabilizer? Because to me, it sounds like you're saying every time we increase, we don't discontinue.
Okay. So you are going to decrease your mood stabilizer when you have an inhibitor into the second medication that's causing for a toxicity level.
Talking about in regards to mania.
Okay.
In regards to mania, not. I know in regards to when you have toxicity or anything that says severe, you discontinue. But I'm talking about in regards to mania specifically, because what you have here, you said discontinue when you're being treated for induced mania. But then how would I know to discontinue versus increase? Because it sounds like for me,
okay. So the question said here, the patient diagnosed with bipolar experienced mania and insomnia despite stable lithium for the past 6 months. So the patient was stable and something was added. So when to increase the medication is when something else is added and is destabilizing your patient.
Okay.
then you are going to increase.
Okay.
When to discontinue or decrease the dose is when do you have an inhibitor added to the second medication that caused an increased level. So now you want to decrease. Okay. So that's why knowing the acronyms for cell and at least one of the inhibitors or inducers will save you when this type of question comes along. Okay. So now let's see the other way around. Well, let's see. Someone else can read this question for me. Anyone, please?
A 58-year-old male patient with bipolar disorder 1 has been stable for the past 5 years on Valproic and Seroquel. Recently, he was prescribed Flonase by his primary care provider. Which medical condition is most likely to occur due to the addition of Flonase to this patient regimen? A, hypertensive crisis. B, Stevens-Johnson syndrome. C, neuroleptic malignant syndrome. D, mania episode. D, mania episode, because Flonase is a steroid.
Okay, so that is the right answer, right? So Queen, do you see how she picked Flonase out of this as mania, and that the mania, you know, the steroid that causes mania, so she's going to decrease the medication in this case, right? Or increase the medication, sorry. Increase the medication. I'm sorry. So you want, if the patient is in mania, you want to decrease the medication. But if it was, I'm so sorry, let me repeat this. So because the medication was added, Flonase, and caused a destabilization of your patient, now you want to, if the patient is in mania, you want to increase your medication. Okay, does that make sense? Because now the patient was stable, it now is unstable. In the question, if I ask you which of the following options would you do, then the answer would be to increase your valproic acid. Okay. Does it make?
Dr. Lo,
Go ahead.
in this case, they are on 2, Valproic and the Seroquel. So which one are we increasing? Are we doing both or just the stabilizer?
Yes. So I'm going to answer this question on the next question here about valproic. So a 58 years old patient has been stable in the past 5 years of valproic acid and Seroquel. So that was the regimen, right? They were being stable. So recently we were prescribed Flonase that destabilized the patient. Which of the following medications is likely to occur due to the addition of Flonase? So in addition to the Flonase, cause is a steroid, so it causes mania, right? So what is your action? To increase either valproic acid or Seroquel. Now, because this is more of a mood question, valproic acid would be the best choice here. Okay. Now let's see the very similar question. Next, can you read the next question here? I think it's next question. Let me see.
Can I ask one question?
Yeah, I don't.
One.
Say it again.
Can I ask one more question about that previous?
Sure.
So in the event you increase either of those mood stabilizers, would you also discontinue the Flonase and do something non-steroidal?
I mean, you
for
could.
For that acute episode?
Yes. So in that case, right, you want to collaborate with the primary care provider. Yeah, we're not going to go in a very details, a lot more than what the question would ask, but in real life, you would, option one is increase your medication, which will be valproic acid. Option 2 would be to collaborate with the primary care provider. Those choices, either one of them, are very high yield as the answer choice, but they would not be necessarily A or B. But if that comes, your action is to control the mania. So in that case, valproic acid.
Got it. And I know the test is not going to ask you in-depth things like that. I was just asking more for like real
Yeah.
life.
Yeah. Now let's go back because I thought I had a question here and it's not in this slide. Now let's go back to a similar question here. Let's say you have a 56 years old, 58 years old male with bipolar 1 that has been stable for 5 years. Well, let's say take the stable out, but say been on valproic acid, Seroquel, recently had an increase in psychosis. But the question is about mania and bipolar. And then which of the following medications would you prescribe or increase the dose? Would there be Valproic or Seroquel? So Seroquel. Seroquel is the answer. Why? It's because of the psychosis, which is different than mania. Okay, I just want to point this out since I don't have a question here on that. I thought I did. I do have any other slides. But if you are treating the psychosis, then you are treating with antipsychotic medication, right? If you're treating the mania, you're mainly treating with mood stabilizer. In real life, I treated both with both. I looked at the Canadian CPG clinical practice guideline. Excellent. I think it's one of the best guidelines that I find out there. Absolutely wonderful. It tells you everything, how to do it, when to do it, all the examples. Wonderful. It's called the Canadian CPG guideline for manic episodes. Okay. All right. So we're moving on because we do have quite a bit and I don't want to take much of your time. Now, remember,
you said Canadian CPG? C
yes.
as in Paul.
Yeah,
CPG
clinical.
guideline.
Yeah, clinical practice guideline, CPG.
Guideline. Okay, thank you.
For mania. So we talked about the medication that causes mania. Now let's talk about the other acronyms you need to know, which is the medication that causes depression. So ASAP, ABBs. You need to memorize this one. ASAP, ABBs. Because now if it doesn't fall into inducers or inhibitors, but it falls either in Forcell or ASAP ABBs, which is A for antiviral medication, S for steroids. Oh, wait a minute. Steroids could cause mania or depression. Yes. Prednisone. A is for Accutane. Oftentimes, you will see if you are working in a big hospital when your patient is stable and they go to dermatology and dermatology will send you a text and say, hey, by the way, I'm adding Accutane to the regimen of this patient. It's because Accutane could cause depression and your patient isn't on a antidepressant medication, right? Accutane could also cause birth defect, high yield. P for progesterone hormonal therapy could cause depression. A for antiemetic meds, cancer medication. So let's stop here for a second. Your patient is on this medication, vincetrine, and many other medication. Which of the following SSRIs would you most like, which of the following antidepressants would you most likely prescribe for a patient that's taking many medications and cancer-specific medication? Lexapro.
Sertraline.
Lexapro. Yeah. More specific, I mean, not that certainly is wrong, but Lexapro is the least drug-to-drug interaction. So think about someone that's taking cancer. Think about your med-surg days if you started with med-surg, right? If someone is taking a drug because of to prevent rejection, rejection, right? You don't want anything that mixes with those medications. So Lexapro would be your answer choice. If we're talking about it, it's because it's high yield, right? So Lexapro would be a good choice. So B for beta blockers, propranolol, right? So let's talk about propranolol because it's high yield too. So if your patient is an asthmatic patient, is taking an inhaler, would be okay for you to prescribe propranolol, yes or no?
No.
No. Why?
It will exacerbate the
Bronchospasm.
Bronchospasm. Okay, guys, I know this is out of the topic, but it's still super high yield for you to know. Okay, so first, least drug-to-drug interaction, Lexapro. Second, never prescribe propranolol for someone that's taking an inhaler, right? Albuterol. The question may not go all the way to say that's inhaler, just say albuterol, right? And you can even say, you know, albuterol, do not prescribe. And the question will pose as in someone in distress and anxiety and so forth, and give you propranolol as the answer. Do not pick propranolol. Benzodiazepine could cause anxiety and depression. Interferon, right, could cause anxiety and depression. And the statin, I've seen questions with statin before, right? So the patient was stable, now added the statin to the regimen. What is your action? Increase your antidepressant. Or what caused the increase in depression was a statin. But for you to know that statin is the medication that caused the increase in depression, you need to memorize ASAP, ABBs. I would highly put those two acronyms on my dumping sheet. Okay? So be aware of medications additions or indications, right? And why they was added. Anytime a question says the patient was stable on X, Y, and Z, something else was added, then you got to decide, is this inhibitors or inducers, or is this four-celled ASAP ABBs that we just covered? Medication that causes mania or medication that causes depression. Okay? So hopefully this makes a little bit clear. So you have to memorize those acronyms. Those are good acronyms to know. A patient exhibits symptoms of depression and is concurrently treating for hypertension and asthma by primary care provider. Which of medication listed below would worsen the depression? A, omeprazole. B, propranolol. C, levothyroxine. D, clarithromycin. Right? Becomes a hard question between B, C, and D. Right? But because we know our acronym, we know that propranolol would be the answer choice. All right? So please know your acronyms, specifically those that I'm spending time more than usual to cover the subject. All right, moving on. We do have quite a bit to cover for the rest of the day. It's about 23 topics, main topics, right? And lots of subtopics that we're covering. So now that we covered inhibitors and inducers, and we cover medication that cause anxiety, depression, and mania, now let's take few other medications. So when someone says, do I need to know psychopharmacology in depth? No, you don't. All you need is the medications that we're covering throughout the course, specifically today. So remember that there are two medications that causes agranulocytosis. One we cover as carbamazepine. The second one is clozaril. So clozaril could cause a decreases risks of a neurotropenia, which requires you monitoring your absolute neutrophil counts, ANC, right? Now, what is a normal white blood count levels? You know, anywhere between 4,000 to 11,000 would be considered normal. Go ahead, Helen, do you have a question there? If you do, please unmute yourself. You are muted.
My question would be, all this that we are going through today, would I find this in the PDF section?
Absolutely.
Okay,
Yes.
That's all I need. Thank you.
Yep, is in a PDF. So, two medications that causes agranulocytosis, clozaril, carbamazepine. So, when do you know it is agranulocytosis? When the ANC levels falls below 1,000, or when patients develop any signs of infection. So, sore throat, right? Beautiful question. 35 years old, taking clozaril, feeling super well. Patient has been stable on clozaril for 1 year. ANC level is 2,000. Recently, the patient complained of a sore throat. Which of the following actions would you do? Collect labs to ensure the ANC level is at the proper amount. B, continue the medication as prescribed. C, stop the medication immediately. Or D, I don't know, make something up. So the answer here is very similar to the question about ADHD. Everything is beautiful, everything checks. But the disguise message is the sore throat. The disguise message is the signs of infection, a low fever, a chill, sore throat, weakness. In that case, you stop the medication despite of a white blood count level, despite of any other levels. All right, so very careful. Okay, so what everybody knows, you stop the clozaril, carbamazepine when the signs are, when the labs is less than 1,000. Everybody knows that, right? But when the question poses as in everything is okay, everything is normal, just like ADHD, where everything is fine, you prescribe the medication, the patient is thriving, but develops a tic. That's the only thing. Your action should stop the medication. Here, your action should stop the medication because of a sore throat. Be careful not to say, in my hospital, I wouldn't do this, X, Y, and Z. This is a test, is your immediate action for the test. Okay? So other things to remember, look out for ANC levels less than 1,000. You want to observe for fatigue, weakness, zero and achy sore throat symptoms. Any type of fever. Don't care if it's a 100.5 Fahrenheit, right? So it's very low fever. Stop the medication, right? So they usually don't go how to prescribe clozapine. So I'm going to skip that part, okay? Now, clozapine may increase your salivation, seizures, and myocarditis. This is important, myocarditis. So one that having a heart problem and taking clozapine should be assessed by cardiology. Clozapine and cardiac issues, specifically myocarditis, should be assessed by cardiology, okay? So observe if it's reversed for treatment-resistant schizophrenia, meaning that ideally you should have tried 2 second-generation options before you choose clozapine for someone with schizophrenia symptoms. Now, remember, there are two medications that could decrease suicidal ideation and behaviors. One, lithium for bipolar. Two, clozapine for patients with schizophrenia, schizoaffective disorders. And before we forget, remember olanzapine and clozapine and their relationships with smoking that we covered earlier today. Lots of details, right? So, can someone read this question, please?
I can read it.
Thank you.
You're welcome. Which cytochrome or CYP enzyme is a tobacco inducer when an individual is treated with clozapine? A, 2D6, B, 1A2, C, 2C19, or D, 2C9? I believe the answer is B, 1A2.
Is everybody seeing the same slide that
Yeah,
she's seeing?
I'm not seeing
That one. I was wondering what she's reading.
I don't know what
Oh,
she's
am I
reading.
reading the wrong question? I'm sorry.
Okay. Just want to make sure it wasn't me. Go ahead, read
No,
this
no,
question,
it's
please.
definitely me.
Okay, go ahead, please.
Hold on one second, please. You know, I can't, forgive me, I can't see the screen. I'm doing a different, I'm having injections in my eyes for diabetic retinopathy, so my eyesight's very poor. I apologize.
No worries.
I can do
Anybody?
it.
I'll
Go ahead,
default
please.
to a person with good eyesight.
All right, here we go. What are the most concerning signs a PMHNP should know when a patient on clozapine? A, bleeding, gums, nosebleed, skin rash, aplastic anemia. B, mutism, muscle rigidity, and hypothermia. C, fever, sore throat, and chills. D, ataxia, confusion, and hypothyroidism. I would choose A for bleeding gums, nosebleed, skin rash, and aplastic anemia.
Okay, so
Aplastic anemia.
okay, so great answer. But let's talk. Let's dial back a little bit. Let's dial back a little bit. Which medication do you remember that was FDA warning for bleeding gums, nose, skin rash, and aplastic anemia?
What are you talking about?
Hold on, guys. Just wait, because if you have your mics on, please mute it. The person that was reading was Neptune, right?
Yeah, I thought it was Clozaril.
No, right? The two FDA warnings for what is that medication?
Aplastic anemia, that's what the gums is. So it has the diagnosis on the symptoms that are happening. So that's kind of weird. But the mutism and muscle rigidity, that's like NMS, isn't it? And then, and then fever, sore throat. Okay, yeah. Fever, sore throat. That could be an answer because that's infection.
Correct. So that is the answer.
Oh, that's the answer.
Yeah, that is the answer, right? Because of infection. So remember, bleeding gums, nosebleed, skin rashes. Guys, which medications are you?
Bro?
I think someone's kid is on a mic. Please don't do that. Thank you. I appreciate that.
That would be valproic acid, aplastic anemia.
Okay. Okay. So, yeah, aplastic anemia, right? So aplastic anemia. So more, yeah. So aplastic. Hold on a second, guys. So let's go back to the initial answer here, so I don't confuse anyone. So the answer is fever, sore throat, and chills. right? So this is what we're looking for, right? Now, when we say
Hey,
breathing down,
my body. I even
guys,
need you to
please,
massage
please,
me.
please mute your mics. Thank you. So the way we can get this going. So when we say skin rashes, aplastic anemia, right? So we had two we had the FDA warnings for Depakote. We said liver toxicity and aplastic anemia, right? So there is a mix of things going on there. Now, if we look at B, we have a mutism, muscle rigidity, and hypothermia. What would that be like? Which condition? NMS. NMS. If we look at ataxia, confusion, and hypothyroidism, which medication would that be high yield for?
Serotonin syndrome.
Lithium.
Lithium, right? But sure, I mean, we can look at other things, but more specifically, we're looking at lithium here. Okay, so now if we talk about carbamazepine, then we will be concerned with agranulocytosis, Stevens-Johnson syndrome, right? What else for carbamazepine? An Asian population, right? Aplastic anemia as well. So, yeah. So now let's go ahead.
Dr.
Go ahead.
Lopez.
Go ahead.
Dr. Lopez, I just want to clarify, make sure you just said for bipolar, for suicidal, lithium is the best medication, and for schizophrenia, clozaril is the best, right?
Yes.
Okay, thank you
Correct.
so much.
Yes, absolutely.
Dr. Lopez,
Yes.
I just want to
Go ahead.
clarify as well. Now,
Yes, please.
I know I'm a little sleepy, but you just said valproic acid was hepatotoxicity and
Valproic acid.
aplastic anemia. That's not correct.
No, that's not. So
Okay.
let me clarify. So Depakote, you have liver toxicity and pancreatitis.
Yes, that's correct. Okay.
Agranulocytosis.
That's what I was thinking.
Agranulocytosis. You have aplastic anemia.
And that's Tegretol.
Tegretol, yes.
Yes.
That is
Okay.
Tegretol. Thank you for that. If I misspoke in there or was too fast, I appreciate that for sure. That's always good to clarify. So olanzapine, right? Then again, we are going back to something that we covered today. Now it is the question about which receptor? 1A2, right? And what's most high yield about olanzapine is likely to be the #1 medication that causes metabolic syndrome, right? Now, it also interacts with inducers. How many times we talked about inducers and carbamazepine? A lot, right? So carbamazepine induces almost everything, right? And the relationship between clozaril and olanzapine is the smoking sensation, or smoking would cause a decrease in the drug. Therefore, you need to increase your dose. Okay. Metabolic syndrome. The first sign of metabolic syndrome, physical sign, would be increase in waist circumference. Now, other things that also we see on tests is Zyprexa or olanzapine. Because of the metabolic syndrome, they would also have something called arcus senalis, which can be associated with hyperlipidemia and increased in heart risk, heart conditions, heart disease. Okay, so we talked about lots of Zyprexa. We talked about the receptors, how it is related to tobacco smoking and clozaril. Very high yield. The first sign that you see with someone metabolic syndrome is increase in waist circumference. Okay, because olanzapine can cause metabolic syndrome. You want to monitor lipid levels and abdominal circumference. And we talked about arcus sinalis, which basically is hyperlipidemia, right? And could increase the problems with heart conditions. Once again, clozaril, it falls into the same category of antipsychotics that could cause increase in waist circumference. We talked about interactions. Inducers can decrease the drug levels, causing a subtherapeutic. Inhibitors can increase the drugs levels, causing toxicity. So clarithromycin and ketoconazole would be the examples of inhibitors. Okay, so this is more of the same thing that we just covered. Now, which CYP enzyme in tobacco inducers when the individual is treated with clozapine? We said 1A2.
Sorry about that. That's me
Yep.
popping back in. I was the one
That
that
is the
Early.
question you were talking earlier.
Sorry about that.
All right, so we're almost done here. Let's go to the next training. Okay. Okay, so hopefully you guys are seeing my screen is being shared right now. So now let's talk about a few other medications that you need to know. Okay, so when focusing on understanding some key principles of medications, one that you need to be aware of is Wellbutrin. Okay, Wellbutrin does not have serotonin. Because it does not have serotonin, it does not potentially cause sexual side effects.
Wow.
Okay, so for patients that are at risk for seizures, it is contraindicated. It is also contraindicated for patients with anorexia and bulimia. Okay, so it decreases the seizure threshold. Now, it could cause priapism, which is a prolonged erections of the male part, and can be a side effect also of a trazodone and Wellbutrin. So both could cause priapism. Oftentimes is you see this question comes up on which ethical principle would be applicable when you withhold a medication for a patient that had symptoms of priapism, and that would be non-maleficence, because you were withholding a medication which is causing no harm, right? Priapism, you could see that come up for either trazodone or Wellbutrin. Okay? More trazodone, by the way. So SSRIs, low drug-to-drug interaction, particularly Lexapro. TCAs, very good for pains, but it's not as safe as SNRI. When choosing between a TCA and the SNRI for pain, pick a SNRI. High yield. What is the reason SSRI is the first line of medication for patients with depression because of its low risks for overdose. Nothing else. It is not more effective than a TCA. It's not better than SRI. Better, I mean, results-wise. But it's the least harmful if someone ingests an entire bottle of a medication. That is high yield. Also, in DRI, so norepinephrine, right? It's very good for depression, low energy, fatigue. Also, if the question says questions like depression, low energy, and fatigue, you could think automatically, well, Wellbutrin, right? No energy, no problem. Norepinephrine needs dopamine. Duloxetine, very good for neuropathic pain. Okay, so that question comes up often. So what do you need to know? Remember the contraindications of a Wellbutrin. Remember the contraindication of for trazodone, priapism. Understand how these drugs interact and why you're choosing Wellbutrin over a SSRI. Understand the least drug-to-drug interaction for SSRIs. And the reason why an SSRI is prescribed as the first choice medication. Which medication acts as both norepinephrine and dopamine reuptake inhibitor? Bupropion, sertraline, clomipramine, or duloxetine. Someone said D. So,
A.
So yeah. So it acts as both norepinephrine and dopamine reuptake inhibitors, right? A. Right? So very important. Okay, very important. And this is why we prescribe that medication as the first line for those with sexual side effects, because it does not have serotonin. Okay, so guys, it is 10:15. Let's take a 5 minutes break and then we'll finish it off in the next 45 minutes. Okay, so 5 minutes break, walk around, please take your bathroom break, and then we'll be done very